Hey there, and welcome to This Explainer. Today, we're diving into one of the absolute most fascinating and, honestly, high-stakes arenas in all of human physiology. We're talking about cholinergic pharmacology. Basically, this is the delicate biological balance of your parasympathetic nervous system. You know, the system that tells your body to rest and digest. But here's the thing. Manipulating this system is literally a razor-thin tightrope walk. If you pull the right lever, you can miraculously kickstart a failing organ or completely reverse a toxic poisoning. But pull the wrong one, you could tragically trigger a lethal medical emergency. It is all about acetylcholine, and it is all about balance.
Okay, let's just dive right into our roadmap for today. First, we'll meet the cholinergic system, then we'll look at direct-acting muscarinic agonists, followed by indirect anticholinesterases. After that, we'll cover organophosphate poisoning and its treatment, touch on nicotine and ganglionic effects, and finally wrap up with some high-yield exam pearls.
All right, Section 1. Meet the cholinergic system. This is basically the body's baseline. Before we start throwing drugs into the mix, we really need to establish how the body naturally operates when acetylcholine is just doing its thing. So, what exactly are we dealing with here? Well, cholinergic drugs are basically agents that either directly mimic the action of acetylcholine, which we usually just abbreviate as ACH, or they increase the availability of it at your muscarinic and nicotinic synapses. Essentially, you've got two strategies. You either introduce a drug that acts exactly like the natural chemical, or you do something that causes the body's natural chemical to just build up in the synapse.
Now, when acetylcholine acts on your parasympathetic organs, the effects are literally everywhere. Think of it like hitting the brakes and focusing on internal maintenance. In the eye, it causes miosis, so your pupils constrict. In the heart, bradycardia. It lowers that heart rate right down. In the lungs, it triggers bronchoconstriction. In your gut and urinary bladder, it increases motility and contraction. Oh, and it totally ramps up secretions. So we're talking salivation, tears, sweating, the whole shebang. If you lock this baseline physiology into your brain right now, pretty much every drug effect and toxic symptom we talk about from here on out is going to make perfect, logical sense.
Let's move right along to Section 2, direct-acting muscarinic agonists. This is where we manually tip the balance. We're starting to actively interfere with the system using drugs that go straight for the receptors.
To remember our direct agonists, just think of this simple mnemonic. Betty picks carrots. That stands for Bethanechol, Pilocarpine, and Carbachol. Now, let's tie these drugs right back to that baseline physiology we just talked about. Bethanechol selectively stimulates the urinary bladder and GI tract. So if a patient has postoperative urinary retention, they can't pee after surgery, this is a total lifesaver because it literally jumpstarts the system. Pilocarpine, that produces meiosis and opens up drainage in the eye, which drops intraocular pressure. That makes it absolutely crucial for treating acute glaucoma. It also really ramps up secretions, making it great for treating severe dry mouth, or xerostomia. And Carbachol? Well, that's similarly used for glaucoma. The drug directly hits the receptor and the target organ reacts. Boom.
But that actually brings up a really fascinating alternative. What if we don't stimulate the receptor directly? What if, instead, we just stop the biological cleanup crew from doing its job? And that naturally leads us into Section 3, indirect anticholinesterases. We're inhibiting the enzyme here. This is a totally different mechanism. Instead of pretending to be acetylcholine, these drugs just block the enzyme acetylcholinesterase. By blocking the very enzyme that breaks the acetylcholine down, the neurotransmitter just pools up at the synapse. The result? Massive, prolonged cholinergic stimulation.
Now, pay close attention here, because there's a critical chemical distinction between two of these drugs, neostigmine and physostigmine. Honestly, this is a massive high-yield trap. Neostigmine is a quaternary compound, which means it carries a charge. Think of that charge like a giant red flag at the blood-brain barrier security gate. It simply cannot get in. It stays in the periphery, which actually makes it perfect for treating myasthenia gravis by improving skeletal muscle strength. Physostigmine, on the other hand, is a tertiary amine. It easily sneaks right across the blood-brain barrier. So if you have a patient suffering from antimuscarinic poisoning like atropine poisoning, where they're having severe central nervous system delirium, physostigmine is your go-to antidote. Why? Because it can actually reach the brain to fix the problem.
But manipulating this enzyme comes with a pretty major clinical dilemma. How do you differentiate between a cholinergic crisis and a myasthenic crisis? They can look incredibly similar. In both, you've got a patient with extreme muscle weakness.
But here's how you crack the case. A cholinergic crisis is caused by too much drug. The system is completely overloaded. You're going to see constricted pupils and muscle fasciculations, muscle twitching. The fix? Stop the drug immediately and give atropine. A myasthenic crisis, conversely, means the underlying disease itself is just getting worse. Their pupils will be normal, and you won't see any of those fasciculations. In this scenario, the patient actually needs more of the anticholinesterase drug. Missing this distinction in real life? Yeah, that can be disastrous.
Which brings us to Section 4, organophosphate poisoning. This is what happens when the system is locked permanently on. We're stepping right into the emergency room now, so let's pick up the pace. Organophosphates were originally developed as nerve gases in agricultural insecticides. In other words, they are literally designed to be lethal. The absolute terror of organophosphates comes down to one specific molecular event called aging. When an organophosphate binds to the acetylcholinesterase enzyme, it starts a ticking clock. Over time, that phosphate enzyme bond gets stronger and stronger. Once aging occurs, that's it. The enzyme is irreversibly inactivated. It cannot be regenerated. The patient is literally drowning in their own acetylcholine, and you have an incredibly small window of time to act before that bond becomes permanent.
So what does this actually look like in a patient? It is a violent, overwhelming surge of the parasympathetic system. We use the mnemonic dumbbells: diarrhea, urination, meiosis, bradycardia, bronchospasm, emesis, lacrimation, salivation, and sweating. It's a lot, but focus on those killer bees for a second. Bronchorrhea, bronchospasm, and bradycardia. The patient's lungs are rapidly filling with fluid, their airways are constricting tightly shut, and their heart is slowing to a crawl. These killer bees, they are the primary reasons this poisoning is so incredibly lethal.
So how do you save them? You have to follow this exact 4-step treatment protocol, and you got to do it fast. Step 1, push atropine immediately. This blocks those deadly muscarinic effects. Step 2, administer pralidoxime, also known as 2-PAM. This drug can actually pull the organophosphate off the enzyme and reactivate it, but only if you give it before that aging process we talked about completes. Step 3, give diazepam to stop the central nervous system seizures. And Step 4, provide aggressive ventilatory support because their respiratory muscles are going to be completely paralyzed. It's a terrifying, high-speed clinical scenario driven entirely by enzyme kinetics.
Okay, let's step back from the ER for a second, take a deep breath, and move to Section 5, nicotine and ganglionic effects. These are our autonomic outliers. Up until now, we focused really heavily on muscarinic receptors, but remember, acetylcholine acts on nicotinic receptors too.
Nicotine actually stimulates these receptors in the autonomic ganglia and the central nervous system. This triggers a massive release of dopamine, which of course drives its highly addictive nature, but it also causes increased blood pressure and tachycardia. This constant cardiovascular strain is exactly why nicotine use is so tightly linked to hypertension and heart disease. But on the therapeutic side of things, we have varenicline. It's a partial nicotinic agonist. By just partially stimulating the receptor, it takes the edge off nicotine cravings and withdrawal. It's a really effective tool to help patients finally quit smoking. All right, let's bring it all home with Section 6, high-yield exam pearls. This is our final review. Whether you're studying for boards or just want to make sure you remember the coolest parts of today's explainer, let's do a rapid-fire run through the absolute must-know takeaways. So, the crucial point here: if a patient presents with severe dry mouth, maybe from radiation therapy or Sjogren's syndrome, the drug of choice is pilocarpine. It directly stimulates those glands to get the saliva flowing again.
Next pearl. If a patient just cannot void their bladder after surgery, remember our friend Betty picks carrots. Bethanechol directly targets the smooth muscle of the bladder, causing that detrusor contraction and resolving the urinary retention.
Pearl number 3. If you've got a patient who is wildly delirious from antimuscarinic atropine poisoning, you absolutely must use an antidote that crosses the blood-brain barrier. That drug is physiostigmine, our tertiary amine. Remember, neostigmine will not work here.
And our ultimate emergency pearl: the antidote combo for a patient who is drowning in their own secretions from organophosphate poisoning. It's atropine to block the receptors, plus pralidoxime to rescue the enzyme. But again, only if you give it before irreversible aging occurs. And that brings us to the end of our journey today. But I want to leave you with this one final thought. How wild is it that manipulating a single neurotransmitter in the body, acetylcholine, can either miraculously restart a stalled bladder and reverse a deadly poison, or, tragically, shut down the lungs and the heart in a matter of minutes?
It all comes down to the magnificent, incredibly delicate balance of your autonomic nervous system. I really hope this explainer helped illuminate the logic behind the pharmacology for you. Thanks so much for joining me on this deep dive, and as always, keep seeking out the why behind the science.